Potential Not Pathology, embracing creative and resourceful approaches to psychotherapy with author and therapist Dr. Paul J. Leslie.
Welcome to Potential Not Pathology, where we offer information and inspiration for mental health therapists who are interested in learning and applying unique therapeutic techniques and concepts into their work, with a focus on the potential each client brings to his or her therapy session. This program examines ideas and tools which can assist your clients on their journey toward healing. I'm Paul J. Leslie. I'm glad you're here. Today we are going to be talking with Dr. Scott Miller. Scott's a wonderful guy. He's just does some really wonderful work, and I think you're going to get a lot out of the interview. Scott's PhD in counseling psychology from the University of Utah, and he's the founder of the International Center for Clinical Excellence, which is an international consortium of clinicians, researchers, teachers dedicated to promoting excellence in the field of behavioral health. Now, Scott conducts workshops and trainings all over the world, and he is just kind of spreading many of his exciting ideas and research findings that I think we need to hear. He's a constant presenter at the Evolution of Psychotherapy Conference, and he just really inspires a lot of people with the work he's done. In this interview, we're going to talk a lot about what we're going to be talking about: feedback-informed therapy, which is something that Scott's very passionate about, and also the fallacy of the term evidence-based therapy. We kind of discussed that a little because I felt that too many practitioners were getting hung up on trying to find a type of therapy that's evidence-based, and Scott talks a little bit about why this might not always be as it is sold to this therapy consumer, shall we say. He also talks a great deal about the importance of the therapeutic relationship, and this is the one piece of the puzzle that doesn't seem to go away, as the relationship is still one of the primary determinants of how effective therapy will be, as Scott will discuss. And most importantly, feedback from the client, as we don't spend enough time as clinicians getting that feedback that we probably should from our clients, and how this can increase outcomes in the therapy room. So I hope you enjoy this great interview, and I really appreciate Scott taking time out of his busy schedule to talk to me. Scott Miller, welcome to Potential Not Pathology.
Thanks.
I am so delighted to actually make our schedules work. You are a very, very busy guy lately.
I'm on the run a lot, and between that, and doing research and having a family life, I am occupied much of the time. But I'm grateful to be here with you today and talk about these important ideas.
Oh, thank you. Before we get started, for the few folks who have not heard of you previously, could you kind of briefly give a background on kind of what brought you into the field and kind of the things you've been doing up to this point?
Sure. I'm currently the director of the International Center for Clinical Excellence, which is a consortium of clinicians, researchers, trainers, and regulators that are dedicated to improving the outcome of behavioral health services. Really, what we're interested in is figuring out how individual practitioners and systems of care can improve the results of the work that they do, as well as retain more clients and services, given that our dropout rates as a field tend to be high, on the high side. When the people are engaged, we do great work. Unfortunately, we just lose a lot of people along the way.
Yeah. That's the kind of the big thing, kind of the overarching, I guess, concept I'd like to talk with you about is about losing people along the way. Why is this such a hesitancy, do you feel, for a lot of therapists to actually kind of just check in with their clients through the course of a session, or at the end of every session, or even after a few sessions. It seems like sometimes they're hesitant to say, okay, how is this going?
Yeah, I don't find clinicians hesitant to check in with their clients. In fact, if you survey clinicians and ask them, do they seek feedback from the people that they work with, they routinely say yes, that they do that. What we know is, however, that their assessments of whether or not clients are improving or not are not very reliable, and that they think they check in a great deal more often than not. Than they actually do. So I think those two things combined result in clinicians not really connecting in a way that provides them with the feedback necessary to make adjustments to treatment that will either keep clients who are at risk for dropping out in treatment, or to turn care that is on the way to failure into success.
Mm-hmm. Now, if it's just as simple as which it's not a note, but if it were as simple as just checking in with the clients, that to me, if I'm thinking about on the other side, being a client on the other side of the couch, I would feel more validated, if nothing else. That it's kind of like going to the car salesman, and if he or she never asks, what kind of car are you looking for?
Right.
And as through the test drive, did you enjoy the car? I would feel like, this salesperson wasn't really working with me. So do you find that, that kind of, from the client perspective, people feel more validated when you're checking in with them about the progress?
I don't know the answer to that particular question. What I do know is that even when clinicians say they check in, it doesn't result in improved retention rates. And secondly, that when they say they check in about the results of therapy, whether or not the treatment is making a difference, that doesn't result in better outcomes. Right. And we think what's missing is some valid and reliable assessment tool. It's really we don't expect physicians to be able to guess your blood pressure from the outside. Right. And we shouldn't be asking clinicians to be able to guess with the workloads that they have and the complexity of what accounts for outcomes, to be able to know all the time that their clients are actually progressing or deeply engaged with them. So we think most need a tool. That's what certainly I need. I need some kind of tool to use that will help me in the aggregate determine when we're on or off track and when the client is engaged with me or not. And when you add that to the mix, then you improve clinicians' ability to detect those failing cases or clients at risk for dropout.
Mm-hmm. Now, when you're saying we're assessing, you've been very active with what you're referring to as feedback-informed therapy.
Yeah.
Can you tell us a little bit about what specifically that is? Because what I'm my gut is feeling that this is, and I'm not just blowing smoke up your skirt here, Scott. I just think this is going to be the next really big thing in the field, or at least the concept you guys are going for. Could you tell anyone listening kind of what the concept for feedback-informed therapy is and how it works?
Sure. I can go all the way back to when, for me, it all started. I had two important relationships, clinical relationships, earlier on in my career. One was with Lynn Johnson, a psychologist, who invented a scale that was used, and he recommended it be used to assess the quality of the therapeutic relationship on an ongoing basis. And the other was a professor that I served as a research assistant with, and that's Michael Lambert. Michael was suggesting that therapists measure the outcomes of their work on a routine basis. For me, the entire reason I started doing this was because I had people disappear from my practice and I couldn't figure out why they had disappeared. And I'm not talking about hallucinating why they might have disappeared, applying my theoretical knowledge to why they disappeared, but actually having their input about why some simply vanished and why others, despite the fact that I worked very hard and we seemed to be deeply engaged with one another, didn't get better. And I didn't either know that or I didn't know what to do. And so based on that, and having had a particular case that I was working with, a person that I was working with that went south, I wrote about it in a book called Failures in Psychotherapy that was edited by Jeff Kotler and John Carlson.
Right.
I decided I needed some help to be able to figure out when I was and wasn't off track. And I began using a lengthy outcome measure, the OQ45, Mike Lambert's measure, and then my colleague and mentor's measure, the session rating scale, which at that time was 10 items. And it was a fairly remarkable experience. What started happening was I began getting feedback earlier on that helped me improve the relationship, which led to lower dropout rates and overall an improving outcome in the aggregate with my clients. That over time has turned into what we call feedback-informed treatment, which is simply a form of what other researchers are calling routine outcome measurement, or ROM. And given what you've said and your observation about it, in fact, we've noticed that many organizations are now requiring this, and it's part of the federal mandate in the United States, and will be part of the federal mandate in the United States that all clinicians have to have some outcome component. Now, I'm not a fan of forcing people to do things, but I do think that the research literature is clear at this point that having some help in identifying clients that are disengaged or are not making progress is a very useful and simple way of improving both retention and outcome in care.
Yeah. And just from what I've kind of read and listened to and talking about this, a lot of people, their resistance and concern, if they're listening, may be about theoretical orientation. But this has nothing to do with theoretical orientation, is it?
No, and it really doesn't. It's trans-theoretical. It's more of a Six Sigma quality assurance methodology. FIT contains within it no particular theoretical orientation, no change theory. It's simply designed to alert you and your client to when there's a problem in the relationship or when progress isn't happening at a rate that should be happening in care. So it can be used across modalities. It's trans-diagnostic as well. So it doesn't matter what particular presenting complaint clients are bringing in. We can and should be asking for feedback routinely and doing so in a way that gives us valid and reliable feedback. Again, most clinicians say, and I believe them, that they are asking clients for feedback. The problem is that the way they get that feedback doesn't allow them to have the kind of reliable information they need to make changes that improve outcomes.
Right. And this is something that is goes on like an ongoing basis.
Yeah.
Throughout the therapy. Yeah,
you're going to want to do this, especially from the beginning, since the window of opportunity for causing a change in client's life, we've got 3 decades worth of research showing that generally more of the change that's going to happens rather quickly in services. That doesn't mean we should be doing short-term therapy. It's not an argument for that. It simply means that clients should start showing some improvement sooner rather than later. In fact, the longer a particular relationship goes without any change, the greater the risk of dropout and deterioration in therapy. The same thing with the alliance. The greatest risk of dropout is after the first visit. The modal number of sessions in psychotherapy is 1, and it's been that way for as long as they've been gathering statistics on that. So this is designed to help us avert that possibility, to change the possibility, increase the chances that the client will return for a second appointment.
Yeah. So having kind of talked about measuring outcomes and not being, this is not something that where a practitioner has to change their theoretical orientation. I know you've done a good bit of research about outcomes and, looked at, the I guess I'm going to call this the psychotherapy marketplace, and how it seems like lately, here's the latest, greatest new therapy.
Yeah.
And this has gone on since, Freud started, and then we've had this cascade. And can you kind of, with this idea of feedback, and what has your extensive research shown you about theoretical orientations in general.
Well, let me go back. Let me go back to your last comment
Sure.
and just clarify. You can use the measures and do feedback informed treatment regardless of your theoretical orientation.
Okay.
However, no particular approach, and I know most listeners and clinicians will readily acknowledge this, but I want to make sure I state it for the record, that no one approach works for everybody.
Right.
Otherwise, we'd have one approach.
Right.
We wouldn't have the myriad approaches that we've got. So if that's the case, then at some point, the measures are going to be disruptive to a therapist's way of thinking and working with a case. Mm-hmm. So if the measures are indicating that the client is likely to not make progress or that there are problems in the relationship, one thing a therapist should potentially consider is changing how they think about that person and how they relate to them and how they construe the work that they're doing with them. So, as I say, it is trans-theoretical. It doesn't matter which approach you can use. But if your approach and your way of thinking about somebody isn't resulting in them changing, is increasing the risk of dropout, then maybe we need to change our mind about how we're approaching that particular person. So it can be quite disruptive. In that regard, we also know that in addition to no one model method or treatment approach having superior outcomes for all cases, there are an ever-growing number of treatment approaches. So clearly, if you're going to try to do something different with a client, maybe changing your treatment model isn't the most potent way to secure engagement and a better outcome. There are instead other factors which research shows over and over again result in clients feeling secure and engaged in the treatment process. And the key one of those variables is the working alliance or the therapeutic relationship. If you just look out over the variety of trainings offered that come into your email, in your inbox or are in professional magazines, look at the number that are about improving your therapeutic relationship skills. Hardly any.
Right.
We've got our every particular other theoretical orientation, technique, and model. And of course, depending on which era you grew up in, right now the hot topic is the brain.
Right.
So unless you tie whatever you're doing to the brain, well, then you're really not on the cutting edge, even though when we as researchers compare different modalities over the last 40 years, we find no difference in effect. So what's the practical implication of this? Number one would be to look to variables that seem to have a consistent effect across treatment approaches. If what you're doing isn't helping a particular client, it may be the method, but a much larger possibility exists that the relationship is somehow corrupted between you and that particular client.
You know, as you're saying that, it just popped into my head. One of my mentors when I was in college is a systemic therapist, and he was talking about when he was in a graduate school, and he thought he was, for a student, he thought he was absolutely a rock star. He thought he's going to be the next fill in the blank, somebody just awesome, and he hit this roadblock with this family. And everything he did, it just didn't go anywhere. And, he kind of, the whole, behind the mirror, the supervisor watching. And so they called him out of there, and the supervisor says, go in and apologize to them for your ineffectiveness and ask them what you can do to really help them. And he said, just go in and say it that way.
Right.
And my mentor went in and sat down. He says, everything changed. Progress, started happening, all of that.
Yeah.
And it was that focus on, look at the nice little paradoxical thing I could do, or here's the latest technique, and as opposed to, here's my humanity, and we can form this therapeutic alliance. But he had to come down off his high horse, as my grandmother would say. And I find that for me, that's spot on. When I'm starting to feel like I'm getting too full of myself, or I'm trying to use a tool instead of forgetting that there's a human being in front of me. I think that's, and it is anecdotal on my part, but I would agree. I find that the therapy suffers.
Right. Well, what I often say in discussions like this is that if your client is not making progress, it's probably not because of the absence of some complex technical factor.
Mm-hmm.
It's probably the absence of basic core counseling process, meaning that we haven't understood what the client wants, what way they want it, what role they want us to play, and how they want us to view them as a person in their world. Those are basic things, but the basics are really complicated.
Yeah.
And we don't get much training on those elements. Instead, it's assumed once you've finished and graduated that, of course, you've managed how to actively listen and reflect feelings and understand and collaborate around goals. What we find in measuring clinicians is that they're often expert in a particular approach or techniques, but their management of the relationship could use some work. And what I mean by that is when you have a case that is not making progress, then their management of the relationship is often the problem. Again, back to basics.
Mm-hmm. Yeah. But how do you, okay, now this is, I teach as well. And how would me as a teacher, if I was going to approach seasoned clinicians, and you know the type I'm talking about, who know that they need to improve, but yet they've been doing a certain way and go, okay, it's time to go back to basics. How do you get kind of the minds to be a little open that it's okay to go backwards, so to speak?
Well, I personally, I do find that clinicians' minds are open, but the minds look at the process of therapy through a particular lens, and that lens is the technique. And we're constantly looking for a method that will make us more therapeutic, rather than looking for, why am I with this particular person not connecting? So in order to find out your personal errors where you don't connect with a given client, you have to measure, and you have to find out when your work with a particular client doesn't help them and the relationship is in trouble. Mm-hmm. And then train to that particular deficit. The assumption in most training, by contrast, is that if I learn these decontextualized techniques and apply them to a specific person, then somehow my outcomes will improve. But if I haven't addressed the particular deficit in my own ability to connect with a given individual, then no amount of technique, decontextualized as they are, is going to improve your outcomes. If you think about this, if you're learning a language, going to a classroom to learn that language can only take you so far.
Yeah.
At some point, somebody in conversation has to say, you're not saying it right.
Mm-hmm.
Here's how you conjugate that verb, ask that question, make this statement. Here's how you do it. In other words, you have to learn how to apply the concepts in practice in a particular context. And it's that contextualization that's missing from most continuing education, actually from most graduate school. So the answer is you have to measure and find your errors and then train to those particular errors. And I think if training were changed to fit with what we know about learning and about the development of expertise, clinicians would be fine and have their minds wide open. It's just that that's what the marketplace provides at the present time. Right. And the broader lens is, as we've already mentioned, really focused on this idea that you'll eventually find a technique that makes you more effective.
Mm-hmm. Now, you again, we bring up the marketplace, and that does seem to be what's driving. As again, we hope we find the magic wand to help people. This term, and I don't want to paint you in a corner here and make you say something that you might be misunderstood. So I wanted plenty of time to elaborate on this. This concept of evidence-based.
Mm-hmm.
I mean, this is getting to where it is thrown around way too much
Yeah.
for me. Could you talk a little bit about your perspective of evidence-based therapy?
Well, this whole term to me has been wildly misunderstood, and I would dare say misappropriated by people who want to sell models of therapy to you. So if you look at the actual definition of evidence-based practice, for example, the APA's official definition of evidence-based practice, this is an idea that I can really, really get behind. So here's the definition set forth by APA in 2006. Evidence-based practice is the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. Now, there's nothing in that description that I find objectionable.
No, I'm all in.
I'm all in. We take the research and the expert has to take that data and make it fit the patient characteristics, culture, and preferences.
Mm-hmm.
Now, clinical expertise, according to this definition, and these are direct quotes, includes, quote, the monitoring of patient progress and of changes in the patient's circumstances that may suggest the need to adjust the treatment. If progress is not proceeding adequately, the therapist alters or addresses problematic aspects of the treatment. And the first thing that's mentioned parenthetically is problems in the therapeutic relationship. So evidence-based practice, at least according to all of the official definitions, is a verb.
Mm-hmm.
It's not a noun. It's a way of thinking about how we interact with the people we're supposed to help. And that is, I've got the research in my head. I interpret it and help it fit best the person in front of me. And then I monitor. And if what I'm doing doesn't work, well, then I change what I'm doing. I don't shift the burden to the client, labeling them with a more serious diagnosis or calling them unmotivated or resistant. These are, to me, this is a perfect definition. Now, what I think you're talking about and what I hear constantly when I'm on the road is therapists say, well, we have to use an evidence-based practice.
Right.
As though evidence-based practice is a noun.
Yes.
So, and that's facilitated by professional organizations, I think, wanting to compete in the marketplace, and in some cases, regulatory bodies like NICE in the UK or SAMHSA here in the United States, mm-hmm. that engender a great deal of confusion because they create lists of treatments for which there's evidence. And so clinicians think of that as an evidence-based practice. I'm using CBT for depression because it is an evidence-based treatment. Well, there is no such thing as an evidence-based treatment, no official term of evidence-based treatment. There are treatments for which there is evidence.
Yes.
But here again, that doesn't mean that's evidence-based practice. You still have to figure out whether or not what you've read about fits with and can be integrated into the client's preferences. And secondly, monitor and measure to see if it makes a difference. And if it doesn't, then who cares what the evidence says about that approach?
That one comment that for a lot of people, that's kind of scary to say, who cares what the evidence says? But I think you're saying that evidence-based and evidence are two different things.
Yeah.
I think,
and I'm also saying that can you imagine two clients speaking to one another, and the one client says, my treatment didn't work, and the other client says to them, well, that's too bad. And then the first client originally says or adds, thank goodness, though, it was evidence-based.
You're right.
What client cares if a treatment is evidence-based if it doesn't work? Because what they care is about practice-based evidence. Mm-hmm. Mm-hmm. They care about, did it affect me? So a treatment with evidence does not mean that it will work with the given individual, which is essentially what APA's definition is suggesting. Mm-hmm. Should treatments be limited to those official lists? To me, I find those lists unethical.
Right.
And bordering on malpractice, really, mm-hmm. because it creates a mistaken assumption in people's minds that if they do this treatment, that they're doing the best care that is is available. The best care that is available is the one that helps the client in front of you.
Mm-hmm.
And given all of the data that suggests that virtually all of these methods seem to help some and not others, the real solution to this problem is not deciding before you meet a client what you'll use with them based on a diagnosis, but rather to do what you think is the integration of the best available research informed by the client's feedback.
I totally 100% agree. And I'm also going to add, I know quite a few therapists that would be uncomfortable doing that. They want to cling. I don't want to sound negative, but they want to cling to, well, I'm doing X type of therapy because I have the evidence. And as you said, sometimes that leads to not only, negative outcomes for some clients, but also a lot of rigidity in the interaction.
And again, I'm not interested in fighting with somebody who says that. I guess I'd like to understand, what do they mean by the evidence? If they say there have been studies which shows that it works, to me, I find that rather unimpressive.
Right.
And the reason is there are literally 80 different approaches right now on the Division 12's research, or Division 12's website, clinical psychology website, that work. Mm-hmm. It's like, so what? The question is, how do you know what will work with this person at this time?
Yeah.
At the same time, if a therapist believes in a particular method, we know that those effects, which researchers refer to as allegiance effects, the clinician believes deeply in their approach, and they have a structure and a method for delivering that approach. That's an important part of effectiveness. Mm-hmm. So I am not saying, as I'm frequently accused of, that you can just do whatever you want with people. You have to do something that you believe in, that has an order, structure, and focus, that engages the consumer, and most importantly, results in measurable improvement.
Yeah. Well, I'm sitting here listening to what you're saying, and it's, to me, that's your comments are giving the practitioner much more freedom to be more eclectic. But it also kind of requires some creativity on their part, and in a sense, more flexibility. Now, when we're getting feedback from our clients, if I can use a systemic model about, we're getting the feedback into the system of the interaction. That's the feedback's there is designed to actually adjust as you go along in the therapy. So holding rigidly to something that you have been sold as evidence-based, if you're getting the feedback that says this isn't working, to continue to hold on to that. I don't want to say unethical. I mean, we use that term, but it's not the best practice, I guess.
Well, and here again, the question is, are we talking about research studies or actual individual clinicians? When I'm observing actual clinical work done in the field by clinicians that are adherents or fans of a particular approach, I find those clinicians amazingly flexible.
Yeah.
At the same time, in settings, for example, research studies where clinicians must follow the protocol, we know that when they are given feedback from the client that it's not working, that those clinicians tend to interpret the feedback according to the model that they're using. So let me give you an example. Sure. If a therapist is using a cognitive therapy approach and they are being observed and held to account for the protocol being followed, when the client gives feedback that says, hey, I don't like this, or this doesn't fit me, those therapists are much more likely, instead of viewing this as a problem in the relationship, to view it as another cognitive distortion that needs to be confronted rather than an alliance breach that needs to be repaired. Mm-hmm. We know the outcome of that. Alliance breaches that go unrepaired result in clients dropping out. So I think it's, when I watch clinicians in the field, there's an intuitive sense that what's really important is to keep consumers engaged over simply following mindlessly the protocol. At the same time, we're all acting as though, and frequently our paperwork demands that we say something otherwise.
Yes. Yeah. Do you have a kind of thoughts about the role of the therapist, even though we're talking about the interaction between the therapist and the client, the role of the therapist personally, as in their, as Carl Rogers would say, their personhood, the level of, and I hate to use this term, it's the only thing I can think of in the moment, their level of charisma, of ability to connect. We talk about the therapeutic relationship. What are your thoughts on some people just got it before they even learned therapy?
Yeah. Well, I think that that's the right question to be asking. In the 1980s, the field took a detour. We were doing much more process research, and some investigators were looking at qualities of the individual provider. But in the 1980s, following in the footsteps of psychiatry and medicine, the field adopted the randomized clinical trial as the way to determine what best practices were. And that meant we adopted the diagnostic system, and we randomized people into groups of treatment based on the treatment that they were getting. That eliminated all individual variation. Now, what we were saying was all that mattered was the diagnosis and the treatment that you got, to see if we couldn't find which treatment worked best for which diagnosis. What we know from the research, simultaneously while we've been doing all these randomized trials, is that who provides the therapist is the most important determinant of outcome. Mm-hmm. So certain therapists are more effective than others. But the research has really languished for the last 30, 40 years in the search to create a psychological formulary akin to the pharmacy of psychological treatment approaches.
Right.
So all of that research until recently was on the back burner. Thankfully, now we're returning to where we were 40 years ago and asking questions like, what qualities do therapists possess that lead them to be more effective practitioners? Helene Nielsen-Lee has done some interesting research out of Norway. Here's what she found. She found that therapists who were more humble about their expertise, that had more professional self-doubt, were likely to be more effective than therapists who didn't. So now, and this isn't something you can fake. You can't, right. I don't mean going into the room and saying, "Oh, what do I know?" Right. I mean, when you leave the room, you're puzzled and you wonder, geez, did I do the right thing? You're constantly rethinking what you did. There's one variable that we know about is associated with expertise. Here's another. We know that therapists that are more effective solicit and manage to elicit from their clients more negative feedback in the beginning of the services. In other words, they somehow make it safe for their clients to say, I didn't like this and I don't like that, so that the therapist can make accommodations. Whereas therapists with the poorest outcomes are much more likely to have clients tell them that they're good at their job and then eventually get around to saying what they don't like. Mm-hmm. So we are discovering some of the qualities of those individual therapists that lend themselves to better outcomes. And that's the most exciting area of the research for me at the present time. Plus, what we can do to help therapists develop those qualities.
Mm-hmm. Well, yeah, because it's, and I don't know if it was actually one of your articles or not. I was reading lately where the bulk of the discussion was kind of what you said. It's like you've removed the very thing that may be facilitating the change from the research. And you're not, where's the therapist? Or as Sal Manouchian said, where's the family and family therapy? It's, what's happening in the room? Because this is an interaction. And if we're not looking at those qualities, what makes person A walk in a room and within 5 seconds, people are much more comfortable to share, whereas person B, it takes, 3 sessions. And again, those are kind of hard things to measure, but I agree. It seems like we got derailed on, again, the magic wand, and we forgot that again we're in the people business, and that quality that we bring to our treatments probably intangible on some level, but in other levels, I think we should be investigating it.
Yeah. And, who wouldn't like it if, in fact, we were able to identify exactly what to do that would solve a particular kind of psychological or psychiatric problem? Who wouldn't like that? I mean, this, to me, as someone who was raised in the generation of penicillin and the notion that what you try to do, like a key in a lock, is figure out what treatment will work best and unlock the health or kill the illness. I mean, that's a reasonable thing, I think, to hope for. It just hasn't worked out. Mm-hmm. And for most of medicine, it doesn't work either.
Yeah.
So but I just think medicine is light years ahead, recognizing the complexity of the work. And in many ways, much of the same findings apply in medicine. For example, who does the surgery is much more important than what they went to where they went to graduate school.
Yes.
Or what scalpel they use.
Mm-hmm.
What concert pianist can't play regardless of the piano they're given?
Right.
But we're assuming somehow that we have to have the right piano in order to play the tune.
Right. Yes. Yeah, exactly. I was listening. It's funny you said that. I was listening a while back to, it might have been NPR or something, and they had some classical pianist who could play. I mean, he was like, I don't know who it was. He was a young man, but he could play this most anything. And the interviewer asked him, well, since you can play most anything, is there anything that you wish you could do? And he said, sometimes I just wish I could play like Jerry Lee Lewis.
Yeah. Mm.
And it's like, well, technically you can. I mean, this guy could, but there was something about, Jerry Lee Lewis that in spite of all his technical ability, he couldn't have. I mean, you could change the piano. It's the player. Mm-hmm. And that's hard to measure. So what is your goals to measure those kind of things?
Right.
Oh, man. Well, as we kind of come to the end of a conversation that could probably go on for years, tell me a little bit about how you're setting up your trainings lately. And I want to let everyone know, if Scott is in your area, make it on your must-see list. He's an 11 on a 10 scale. The information's going to knock you out of your seat. It's something everybody, and we've been talking about theoretical orientation, anybody from whatever theory you come from needs to hear this stuff, and because it causes a shift in our thinking. Yeah, you're presenting literally all over the world these days, aren't you?
Yeah, just back from Iowa yesterday, and the week before that I was in New Zealand, and the week before that in Australia. So I do get around, and I'm grateful for your very kind words. I love doing the trainings. I'm inspired by clinicians coming to the workshops and truly pushing themselves and wanting to get better. It's no small indication of just how motivated clinicians are, given the amount of money they spend on continuing education every year. They really do want something. Secondly, when you ask clinicians who they learn from, they say they learn most about how to do their work from the clients.
Yes.
What all we're doing is giving them some corrective lenses for that feedback. We're putting that feedback into sharper relief. And empowering the clinician to use that data to improve their particular skills and abilities, address their particular errors and deficits. So for us, where we're going is, I can say, number one, I'm really not interested in the measures per se, and I haven't been for close to 7 years. The only reason to measure is to give me feedback about where my growth opportunities are. And what our team is currently working on and excited about is taking the data generated by those scales and creating individual taxonomies for practice, meaning that we're helping you create a map of where your strong points are and your weaknesses are as a clinician. Again, regardless of your particular approach, so that you can work to correct those deficits and enhance your effectiveness. And we now have the first study of its kind in history showing that engaging in that kind of feedback and practice leads to improvements in outcome at the individual clinician level. a year ago, in 2015, we published the largest study in history of therapists. We'd followed therapists for up to 17 years, measuring their outcomes. And what we found was clinician outcomes not only didn't improve, they steadily declined year after year. So this is designed to change the direction. And our data indicate that that's what's happening. Is it hard? It's not complicated if that's what you mean by hard.
Right.
Is it easy? Well, it's sort of like investing for retirement. You can't do it at once. You can't sprint your way unless you win the lottery. You can't sprint your way to a fully vested retirement plan. You have to invest a little bit every day in getting better. And that's what our trainings are showing people how to do.
Yeah. Well, what's the best way for people to get in touch with you, to kind of follow what you're doing? Can you give us like your website?
Sure. My website is scottdmiller.com. And I'm also part, as I said at the beginning, of a group called the ICCE, or the International Center for Clinical Excellence. And you can join that website for free. It's a fantastic resource. There are no ads. There's no soliciting, no selling on it. It's just a place for clinicians who are interested in these ideas to meet, talk, and to share their experiences and knowledge. So there are hundreds of articles written by members of the ICCE. There are hundreds of how-to videos that you can all access for free at centerforclinicalexcellence.com.
Okay, excellent. Well, I really appreciate you taking your time today, and I believe me, I know how busy you are, and I really appreciate it. Do you have, in the last few seconds, any advice to, a new or a seasoned therapist who's just heard this and kind of like, what's the best way to go starting tomorrow?
Well, I think the best way to go is to start slow. There's nothing here that you need to buy or I think I would start reading. Go to my website, click on the About tab, look at the publications section, and read, for example, the article, The Path to Mastery, which is a popular article. If you're feeling overwhelmed and burned out, then read Rethinking Burnout, which is another article we did that has all of these topics are related. For example, we know that clinicians do not burn out because of their workload. We know that. We've known that for 20 years. What we also now know is that what burns clinicians out is the number of people they're working with who aren't making progress, but that they continue to work with.
Yeah.
They have to feel successful. And this whole idea, the kind of measurement and practice we're talking about here, is designed to attend to that very specific issue.
That's great. And again, another unsolicited testimonials, a lot of great stuff. And the books you have out too. I think one in particular is not therapy-based. I recommend that as well. You're a really gifted writer, man. I'm telling you. I enjoy reading it.
Thank you.
So again, thanks for being here. Try to at least, spend 5 minutes with your family. I hear that is always a juggling of of priorities, and somebody who lives such a hectic lifestyle as you. And thanks for being with me today.
My pleasure.
Thank you for listening to Potential Not Pathology with Dr. Paul J. Leslie. If you enjoyed the show, check out our website at potentialnotpathology.com, where you will find programs and articles showcasing unique and creative therapeutic applications.